Welcome to chapter 4. In this chapter, we'll start to talk about some of the technology tools that we use to support population health and population health management. Now, what's interesting is I've been using the textbook by these three authors for about 10 years now, and this is the first version of the textbook, edition of the textbook that actually puts emphasis, an entire chapter on specific tools for population health. So we'll start to talk about some of those, how we work under a population health environment with value-based payment models, and then some of those key tools and strategies. And we say tools and strategies, it's not all just technology. And then again, data analytics is kind of the wrapper around this on how we monitor and how we use our knowledge of analyzing data to manage a bigger patient population with the same, or in some cases, even fewer resources. So of course, we'll once again kind of define it, talk about the payment models that fit into this, and talk about the accountable care organizations, the Affordable Care Core process, what HIT can and cannot do. Again, patient portals fits very strongly into this as well. Okay, so population health really kind of reared its head in the early 2000s. And basically, we're saying it's the health outcomes of a group of individuals, including the distribution of such outcomes within the group. All right. Now, what does it mean today? We want to pull together all of these, collage of strategies, if you will, that will help us improve the overall health of the individual while lowering the cost as well, right? So big challenge, right? And those interventions, again, are hopefully geared towards improving health across our entire continuum of care. And while we still want to focus on the one person, we want to focus on the, quote, population. The last caveat to this is preventative medical care. Now, in the US, we are doing a very poor job of this. We historically spend less than 10 cents of every dollar on preventative care. It's more like 5 to 6 cents is spent on preventative care. The rest is all reactive medicine. Okay, so we're trying to shift that continuum, if you will, and population health is one mechanism we can use to do that. Now, we look at two different payment models. One is the standard payment model that we've been using for decades, fee for service. I go to the doctor with a cold, a sinus infection, and I pay a agreed upon rate for that service, right? Whereas the other one is value-based care, meaning, and we've got a couple examples here that we've talked about in prior chapters, but in short, if I'm taking better care of myself, I should get cheaper healthcare. All right. And we've done some good work here, but we still have a ways to go. So when we talk about these accountable care organizations, we work across the boundaries of the organization. All right. We want an infrastructure in place to where we can effectively share data to the right people and really engage those patients in the process, right? And we'll talk a little bit about how personal health devices factor into this as well later. Okay, but we also got to all agree on the same quality measures, both used in public and private programs. Okay, and let me give you an example of one that is constantly brought under fire, and in a lot of ways, rightfully so. One measure that we have used for years to determine if a person is of a healthy weight is BMI, body mass index. Well, what do we use to calculate BMI? We use height, weight, and gender. That's it. Is that accurate? Not always, right? If you have a person that does a lot of physical weight training, they can have a lot of muscle mass. Muscle weighs more than fat. And if we're looking strictly at their height and weight and gender, then the BMI could potentially say that person is overweight. And that might not necessarily be true. Okay, so not perfect, and we've got to align those measures better. With that comes stratification. Okay, we have to be able to pick out a patient or a cohort of patients that is at risk for a negative health event. All right. And again, historically, we have not done the best job of this. And we do a little bit, right? Where we have these campaigns now around vaccination, but prior to COVID, you'd occasionally see, oh, seniors need to get flu shots. We saw a little bit of emphasis around, get the shingles vaccine, get the pneumonia vaccine, but we really haven't gotten into truly finding out what cohorts are at risk and intervening early. Okay, so we've got to have the way to find who's at risk, notify them, and intervene at the right time. All right. So when we think about care management, okay, we have to look across multiple care settings, right? It's not just when they show up at the hospital. It's not that a relatively healthy person might only go to the doctor once a year. So a lot can change with your health in 1 year. So we want to manage some of those most complex patients. And ideally, we want to keep them out of the hospital because that's where our biggest cost occurs, is when they walk through the doors of that hospital. Worse yet, if they walk through the door of the emergency room, which is incredibly costly. Okay. So we get into this accountable care space by contracting and looking at the overall performance. Okay, we look at what the impact of poor care is. Okay, and we, in a perfect world, we penalize for poor care, and we reward for improved care. Okay, and think about this. You could draw the parallel to the automotive insurance industry, right? If I'm a safe driver and I don't get in wrecks, I don't have speeding tickets, and I drive a safe car, I will typically pay a lower insurance rate than someone that's the same age as me, same gender, that lives in the same zip code, that has speeding tickets, maybe has a DUI, drives a car that's not safe. We've realized that person is higher risk for costing the insurance company money. So therefore, the result is going to be, we're going to charge you more to be covered. That's kind of what we're trying to do here with accountable care in healthcare. Okay, so what we don't do a great job is that retrospective, right? What didn't happen and why? So an example, by monitoring a patient's blood pressure at home with a remote blood pressure cuff that connects to the internet and sends results to the primary care provider, and also a scale, a digital scale in the patient's house that tells us how much that patient weighs. Those two indicators alone can tell us a lot about a patient's overall health. And if that data is streaming to the physician and it surpasses a certain threshold, then that care team can get involved, call the patient at home and say, hey, alter your blood pressure medication, or I'm going to prescribe a diuretic, or I need you to come into the doctor's office. Okay. But what it does do that we're not catching always and giving ourselves credit for is, did we keep that patient from walking through the doors of the hospital into the emergency room? Worse yet, did we prevent an ambulance ride? Okay, those are all savings that we can do via accountable care. Okay, and as the text points out, preparation and automation is the key. Okay, we have to rely on these IT tools to help us identify who these patients are. I don't want my care team having to look at endless feeds of blood pressure, digital blood pressure cuffs in the home, and digital scales. I just want them to be alerted of somebody that's way out of bounds. Okay. So we've got to focus on what data is important, and we've got to give that holistic view. We want to see it all, and we want kind of that master index, if you will. I want to know everything that you do, every behavior that has something to do with your healthcare. And this goes just beyond the clinical data. As the text says, it goes beyond the EHR. And we can go down the rabbit hole pretty quick. I'm going to share a video as well that'll kind of maybe get you excited a little bit. But again, this is around looking at, are you coming to the doctor for your regular check-ins? Is the billing getting done? Are you picking up your pharmaceuticals? Are you taking your hypertensive meds? Are you taking your cholesterol meds? And if not, why not? And how do we manage that? Okay. We've got a ton of different systems we can use. But again, we want to look at all of those things. And I stress again, automation is the key here. And as the text points out, if we do it right, a care manager can manage 30 to 60% more of the patient load than they could with doing so manually. Okay. And then the text also talks about some of these rules and workflow engines. Like I was kind of pointing out, I don't want my care team to look at the blood pressure and weight feed from every single patient. I just want them to say, hey, here's the most critical one. Here's the one you need to call right away. Here's the one you need to call next, just to kind of get through that. Okay. So to do that, we got to have the data. We've got to have the data in a way we can get to it. The good news is the technology is there, right? We've got predictive analytic tools that can really help the care team pick out who those patients are. And who's most likely to show up in the emergency room? Who do we go after first? Okay. Access to that data continues to be a problem, but the technology is there to make it happen. Okay. HIE, Health Information Exchange, I mentioned in an earlier lecture, we've still got a long ways to go here. Okay. We've got to better connect the dots and make these systems talk regardless of what vendor platform they're on. What we've seen a lot of institutions and vendors go to is what we call a scorecard, where, for example, if we stick with kind of the hypertension blood pressure example, maybe just a little bit of weight gain isn't horrible, right? So on Monday, I hop on the scale and my weight has increased by 3 pounds. Okay. But my blood pressure is still within normal limits. Maybe I just overdid a little bit at the buffet on the weekend. I got a little lazy and that happened. But maybe I look bigger picture, my scorecard, and suddenly I have a 12-pound weight gain. My blood pressure has spiked significantly. If I have more telemetry in the home, I might see that the resting heart rate has increased. Maybe O2 saturation has increased. And then that might score me a little higher and go, this one is the one that really needs some intervention. Okay. We talk about the EHR, we so often focus what we call episodically. So what am I here for? Am I here for a broken bone? Am I here for the flu? Am I here for COVID? But I really need to be able to look at the complete picture, all right? What we say cradle to grave. Okay. Was I born with a congenital heart defect? Did I have a trauma, in my early 20s? And then I later developed heart disease, all of those things. I need to be able to see quickly, efficiently, and effectively. And part of that comes in mechanism of engaging the patient. And that's where we start to, again, talk about portals. Where I can see all that stuff. I can communicate with my provider, schedule my appointments. Now, what's interesting is the text also calls out social media. And sometimes we think about that under a negative light, and it's certainly accurate to say that. That said, there's some newer studies starting to come out around, can social media motivate people to take better care of their health? And I believe the answer is yes. That's Dave's anecdotal opinion. Don't quote me on this, but what I see on a personal level is, if I share personally, for example, I like to trail run. I like to run through the woods on trails with friends. And this time of year, sometimes it can be a challenge with the weather. It's maybe not the most pleasant weather, and I'll convince myself that no, I don't want to go out. And inevitably, I'll later see that the social media group I'm in for running on the trails, someone will post and say, "Oh man, all of us went out. We had a really good time. The weather wasn't great, but it didn't matter. We still had fun." Now suddenly, I've kind of got that fear of missing out. If you talk about where hey, I could have been there, and why didn't I get off the couch? Next time, I'm going to do that. So those are ways where it can help motivate. It can certainly go to the other way as well. Okay. Next, we got to automate. Automate. You all have likely been recipients of this many, many times, right? Appointment reminders via text message, via email, via phone. And some of you are probably old enough like me to remember when it used to actually be a physical phone call that and some places still do this, where you get a phone call. "Hey, this is Jan over at Dr. So-and-so's office. I just want to remind you, you have an appointment tomorrow at 9 a.m. And it's like, okay, this took a person to call. No, I personally prefer the text. I can see it, double check my calendar, and be sure we're good. Telehealth comes back into this picture, right? It makes access to care easier. It reduces the risk. It makes the interactions more convenient. I can now have access to a specialist without being in the same geography as them. And I can get more data from patients at home. Sometimes just that visual peripheral of seeing what the patient's home looks like. Are they in a safe place? Do they have heat? Do they have air conditioning? Is the house overrun with pets? Is there excessive clutter that creates a safety hazard for a patient that's maybe a fall risk? Okay. We still continue to work with issues around providers getting on board. COVID helped a great deal with this. We also struggle with reciprocity across state licensures. I will say that with COVID, they temporarily suspended the state reciprocity to basically say, if I'm a licensed, care provider in any state, I can practice in all 50, which was huge. And there's hopes that that doesn't roll back. Okay. There continues to be underlying concerns about confidentiality and liability. Okay. Are we standardized with the data? And then, of course, we've done a lot in the reimbursement space, but we still need to do a little bit of work there to ensure that our providers are getting adequately reimbursed for the services they provide. And the big challenge here is a call for equality, right? And what I mean by that is ensuring that if I, as a provider, am taking the time to get on a video session, a telehealth visit with a patient, that I should be reimbursed the same rate as if I was physically in the office. Okay. So again, a couple things around driving adoption for Patient Portal. And this comes from CLAS. You can see in the very top, KLAS. And a funny narrative, I have a lot of people ask me, well, what does CLAS stand for? It's an acronym. Well, it's actually not an acronym. CLAS is a private organization that evaluates health IT vendors and provides scores and evaluates them on a variety of categories. Okay. Best user experience, best support, best in data hosting, best usability, tons of different categories. The KLAS are the initials of the founders of the company. Why they picked that name, I don't really know, but yeah, that's very common nomenclature in healthcare, is the CLAS organization. Okay, so they talk about the big thing is education. Okay, tell patients why, tell staff members why. Okay, give patients incentive to use the portal. And when I help clients with this, the one piece of advice I give is make more appointment options available over the portal than you do over the phone, and incentivize those patients to go in over the portal and do it over the portal. Okay. And you've got to reset some mindsets. I remember working with an OB-GYN group, and the front office manager was struggling with staffing. And I said, well, why don't you, go to a portal to schedule appointments? And that frees up, one resource right there. And her response was, we can't do that because if a pregnant woman is having complications that are urgent and they try and schedule an appointment over the portal that really needs more immediate action, we would miss that and risk the patient. And I said, no, you need to put the correct checklist on the front end that says, if you're experiencing any of the following symptoms or conditions, you need to call immediately, or you need to call 911 and seek medical care. So sometimes it's an uphill battle, kind of changing those perspectives of why. Yeah. Okay, some of the reasons why people like social media, like I said, it creates a sense of community, and that community can be good or bad, right? Like I mentioned earlier, if it's the running community, that's good. If it's the group of people that get together and binge drink, probably not so much. It can be used to share new clinical research and data. You see a lot of groups like in Facebook around awareness of a very specific health issue or personal health issues. Like I see groups on Facebook all the time around a group around like caring for elderly parents, where they share tips and tricks, and they just kind of lean on each other as a support mechanism. Okay. I also see all the time on social media, who can recommend a good doctor, a good doctor for ortho. I need knee replacements. Okay, who can you suggest? I'm having foot issues. Who can suggest a good podiatrist? Okay, so a lot of ways we can leverage this to our benefit. Okay. Okay, so then we think about the care plan. Okay, how do we get there? It has to be transient. It has to be somewhat consistent, have the same bits and pieces. Okay, we have to assess risk. Okay, and again, not all care is going to be amenable to a preferred patient plan, right? So we do have to have some variability there based on the plan, based on the patient, based on the reimbursement mechanism. Okay, and we should rely on evidence-based. Okay, what does our evidence-based medicine tell us? And this gets a lot of attention. We talk about evidence-based medicine. A lot of people say, oh, we're replacing the doctor. No, we're not. What we're doing is we're trying to help the doctor by empowering them with more information to make an informed care decision. Okay, so when we think about the plan-centric EHR, This is talking about a library of plans that cover a wide range of situations. Okay, we use data on the back end. We use algorithms. We use artificial intelligence here to help us identify this and say, where does this patient fit? What do we do? What steps need to be carried out? And let me give you just a real good example where we've been doing this for over 20 years and we've got a lot of data. Okay, patient comes into the emergency room exhibiting symptoms of stroke. The exact steps that the attending physician in the ER might take used to be dependent upon their personal judgment, what I think this patient needs. What we found even 20 years ago when we started to analyze the data was, well, we can't decide how effective we are at stroke care because we're not treating stroke the same every single patient that comes in. So what happened was one particular ER a long time ago said, we're going to use evidence-based care plans here. And you are going to, every time a patient presents with these symptoms that are symptomatic of a stroke, you are going to do the following things. Okay. And it might be some lab work. It might be a CT. It might be a neuroconsult, just a variety of things. And we're going to do that every single time, regardless of who the physician is. And then we're going to look at how effective we are. Okay. As you might imagine, this was met with some resistance from the physician population. But overall, once it was adopted, what did we find? We found consistency of care. We found that the success rate for stroke went up significantly. So what happened? We started doing this with other different conditions of care. Okay, so suddenly came one for chest pain. You show up to the ER with chest pain, here's what we're going to do. Okay, you show up with signs of sepsis, here's what we're going to do. Okay, so it made a big difference. So again, in this unit, we talked about population health and some of the payment models. ACOs, the core practice behind why we do it and what it all means and how we automate for better outcomes. We talked about what HIT could do, a little bit about what it can't do, and then at the end, how we get it down to the care plan. So this concludes everything for chapter 4. So again, as always, please let me know if you have any questions.